Good afternoon, everyone. Thank you all for attending. So this is the first of the All You Need to Know lectures, and I'd like to thank the BAA for inviting me to present this topic, which is monitoring ototoxicity with distortion product otoacoustic emissions. And hopefully, as Kevin was saying this morning, on Monday you will all start thinking about this and hopefully implementing it in your services. So when we talk about otoacoustic emissions, we can see that the search for OAEs has been happening for hundreds of years, since we started thinking, or researchers started thinking, of how the ear works. In the early 20th century, von Becquechet described the traveling wave theory of the cochlea, which earned him a Nobel Prize and was a breakthrough because we started to actually understand what's happening. Shortly after that, Thomas Gold proposed that the inner ear is probably responsible for a bit more than what was described in the cadaveric ears that von Becquechet was testing, and proposed that there's this active mechanical amplifier within the cochlea. This was only proved when David Kemp was able to record otoacoustic emissions, which reflected this mechanical amplifier and traveling wave, and was able to show that the inner ear, through the outer hair cells, was active in providing this high precision and frequency specificity that the ear is capable of doing. It took 10 years for the OAE equipment to be available commercially. And even though lots of clinicians immediately could see the huge clinical applications that we can apply using this testing, it took another decade for the first newborn screening program in the US to be launched. Based on the advantages that we could see for otoacoustic emissions being used as a screening test for cochlear function, and with all these different advantages. The UK followed suit very quickly, and from 2002 to 2011, all 4 countries fully developed their newborn screening programs, and only last year Sally Wood and colleagues published a paper evaluating the first 7 years of the England program, which showed a very, very high level of achievement of the KPIs and over 98% coverage of the newborn population within the UK, within England. The great success of the newborn screening program kind of makes us forget about the other potential clinical applications of OAEs. In monitoring for cochlear function, in assessment and site of lesion assessment, and even assessment of the descending pathways through OAE contralateral suppression testing. And what I'm trying to do today is to highlight its role in monitoring for ototoxicity. So, as you know, ototoxicity is damage to hearing and balance function following exposure to ototoxic drugs and solvents. There are hundreds of drugs that are already known to be ototoxic, some of them causing permanent damage, others not. But we kind of focus on these 2 groups a bit more. So the anti-cancerous platinum-based drugs, cisplatin and carboplatin, and the aminoglycoside antibiotics, mainly because they cause permanent irreversible damage to the ear. They're given on repeated cumulative dosage, and the patients that are exposed to these drugs are also not well. So cancer patients are generally unwell, have lots of morbidities, and aminoglycosides are usually prescribed for patients that have severe, significant infections. Things like patients with cystic fibrosis with severe chest infections, patients having severe infections needing to be in intensive care units, TB patients, and so on. And that is why the hearing loss, because they are surviving these infections and these cancers, now have a significant quality of life issues when they lose their hearing and balance function. And that's why we need to pay a bit more attention to ototoxicity that happens in these groups and even others. The damage that these drugs have on the ear is quite selective and quite specific. So if we see a normal electron microscopy picture here with the normal 3 layers of outer hair cells and inner hair cells, following exposure to ototoxic drugs, the outer hair cells are the first ones to get damaged, and then the inner hair cells follow suit. So that selective damage of outer hair cells makes tests like otoacoustic emissions a very suitable test for us to detect early changes. It also follows a very specific base to apex gradient of damage, so that the basal turn of the cochlea, representing the higher frequencies, is damaged first, and then the damage spreads to affect the lower frequencies. And that's also shown through animal work and lots of other studies. There's also the question of why, if we have a group of patients that are exposed to ototoxic medications, some of them show signs of ototoxicity and others don't. And there's extensive work looking at genetic susceptibility and whether genetic mutations are associated with that increased susceptibility. This is one of the relatively well-established mutations that we have associated with aminoglycoside ototoxicity, the mitochondrial DNA A1555 mutation, which through Maria Bittner's work here shows that patients that have that mutation could develop even severe to profound hearing loss, even from exposure to 1 or 2 courses of these or even doses of these antibiotics. So that's another factor. So basically, we need to monitor these patients, and one of the main rationale for monitoring is we want to have early detection of hearing loss. If we wait for the patients to complain of tinnitus or hearing loss or balance problems, that means that the damage has already happened, and at least half of the cochlea would have been affected because the speech frequencies would have been affected at that stage. We want to detect them early, before the speech frequencies are affected, so that we can make potential changes or modifications in treatment and prevent further damage. It also gives a lot of information for clinicians to make informed choices. So even if they can't change the medication or alter it, it gives them the ability to provide better counseling for the patients and realistic expectations of the patients and know what to expect, and provide rehabilitation through hearing aids, cochlear implants, or assistive devices and so on at an early stage. There are different audiological methods that we use for monitoring for ototoxicity, and research and clinical practice kind of shows that it's still standard pure tone audiometry is the one that is most commonly used, even though, as Kevin highlighted this morning, high-frequency audiometry to represent that basal damage caused by the ototoxic medication could be a lot more useful and give us early signs a lot more. And of course, distortion product otoacoustic emissions, specifically distortion products because they have the ability to test higher frequencies compared to the transient evoked emissions. But there's lots of research to support that these two methods are actually a lot more useful in early detection if this is what we're aiming to do. There's also been a lot of publications from the Portland Veterans Hospital group, from Fausti and et al. And so on, describing this sensitive range of ototoxicity. So what they're saying is you don't even have to assess the whole of the auditory function of the patient. If you assess the highest frequency they can hear before exposure to the drugs, and then focus on 1 octave below that, this is where the hearing loss would occur first. So we can cut down on the testing time and cut down on the effort that the patients have to give with the serial monitoring. So how often and what's the protocol to follow? This is an example of the American Speech and Hearing Association, ASHA, protocol for monitoring oncology patients. So the recommendation is to have serial monitoring. So you start with baseline assessment, and we should kind of do as detailed as possible assessment of these patients. So do a good history taking, tympanometry, assess middle ear function, and then do PTA and high frequency audiometry and DPOE testing and more if we need. And then follow them through by serial monitoring of their hearing throughout every time they get exposed to these medications. For cisplatin, because it's known to be more ototoxic than carboplatin, the recommendation is to do that serial monitoring at the end of each course. Carboplatin is slightly less, or known to be less ototoxic, so the recommendation is to test them every 2 to 4 cycles. But what I'm also trying to advocate is we could use otoacoustic emissions as the primary kind of following serial monitoring test to use because of the advantages that I'll highlight now. And then if we can define specific changes happening, then we can follow on with the full battery of testing, just to make it more doable. Because one of the things that hinders the monitoring protocols is that people say, well, our patients are too unwell to keep testing them that often. So why are otoacoustic emissions useful as a monitoring tool, ototoxicity monitoring tool? As I mentioned, they test outer hair cells, and we know that from the animal studies that the outer hair cells are the first to be damaged with ototoxic medication. They have been shown to identify cochlear damage even before it becomes apparent on the audiogram. And so, again, it's this early detection. And because they are objective, they're fast, they don't need patient cooperation. Now, a lot of the devices are portable, and because we only need to have a quiet background rather than have a soundproof, test them in soundproof rooms, all of these advantages allows us to go and test the patients if they are bedridden or uncooperative or really unwell. We can go to them and we can do this testing, rather than having to get them to us in a soundproof room and do a prolonged PTA testing. There are advantages, and these are probably the things that make people maybe not use them as much as they should be. One of the main ones is that OEEs are known to be affected by middle ear dysfunction, so even a change in the middle ear pressure would have an effect on the OEE response, and so we have to be careful or try to monitor middle ear and external ear conditions as well. There's an issue with repeatability. And I'll talk a bit about that and talk about the test repeatability of that, of OEEs. But that is mainly affected by probe fitting and the difference in time between the baseline testing and the serial monitoring. The other issue that people kind of puts them off is the absence of agreed pass-fail criteria or significant change criteria. And I'll give you a bit of an argument for that as well. So that absence of pass-fail criteria doesn't just apply to OEEs, it also applies to audiometry in criteria for ototoxicity. So this is an example of 4 different studies that were looking at ototoxicity monitoring. And as you can see, they were using PTA and high-frequency PTA testing tools, and each one of them is using different criteria for ototoxicity. And this could be one of the reasons why the reported incidence from these studies is so varied, ranging from 50% to 5%. We also have multiple grading systems and multiple criteria for defining ototoxicity, even for pure tone audiometry, not just for OEE tests. A lot of people commonly use the ASHA criteria for ototoxicity, but there are other grading systems, especially used in oncology, like the Brock's grading criteria, or even the more recent Boston ototoxicity scale, and there are another about 4 or 5 other grading criteria, which makes us not quite sure what we should be using. To show that and to show what's happening currently in the UK, we ran a survey to look at current practice in ototoxicity monitoring in the UK. It was an online survey, and we contacted audiologists, oncologists, and CF clinicians and asked them whether they monitor their patients for ototoxicity or not. Even though nearly 70% of them said that they did, when we asked them a bit more, when we asked for more detail, like what audiological tests would you use, we found and confirmed again that just standard audiometry was the main tool that is used, with very, very few of them actually using other tests like extended high frequency or OEEs or even ABRs or others. Another one that was slightly worrying to us is that the majority of the oncologists actually said, I'm not sure which audiological test is conducted. That is quite worrying because a lot of centers, and the centers that do manage ototoxic patients, a lot of them actually test them in the normal ENT clinics or outpatient clinics. So they test the patient, print off the test results, put it in the patient's notes, and that's it. So it's up to the oncologist or the clinicians to actually interpret these test results and decide whether they're going to use this information to change their management or not. If they're not sure what test is performed, that's a bit worrying. We had an open-ended question that to follow up from that question, and the question was, what changes in audiological results should prompt change in your medical management? And again, we had a huge range of different suggestions, again highlighting that there is no clear criteria of pass-fail or this patient has signs of ototoxicity or not. So we have clear pass criteria or pass-fail criteria for the newborn screening program, and everybody follows that. Why can't we have the same thing for diagnostic DPOE testing when we're monitoring for ototoxicity? We can. It's a bit more complicated, but we can do it. And one of the things we can do is to start by using the same protocols for testing. And this is an example of criteria or parameters to use if you want to use DPOEs for your ototoxicity monitoring. We would use a relatively moderate level of intensity of L1 and L2. 65, 55 is a common one to use. The quieter the sounds, the more sensitive the OEE test to cochlear dysfunction or damage. But if you make it too quiet, then you don't get a clear DPOE amplitude. So it's been agreed that that average level is acceptable. You need to focus on the higher frequencies, and now most of the commercial OE equipment can test up to 10.5 kilohertz, and you would aim to look at a bit more detail. So look at average minimum about 4 points per octave, or go up to even more detail and look at the fine structure of the DPOE. When you're using this as a monitoring or as a diagnostic tool, you shouldn't just focus on the signal-to-noise ratio, which a lot of people tend to use, just making sure that you've got a 6 dB signal-to-noise ratio is the commonest level that's used. You need to also focus on the dP amplitude and try to see if that changes or not. You need to ensure that there's a quiet or low noise level as well to make sure that this signal-to-noise ratio is achieved. To make sure that the recording is good and repeatable, you need to ensure that you are taking some precautions to avoid artifacts. So a good deep probe fitting is actually essential, and if you try to achieve that repeatedly in every recording, you would really improve the test-retest variability for patients. You need to ensure that the middle ear function is stable or isn't changed, because that can have an effect, and just make sure that they're being tested in a quiet condition to avoid internal and external noises. If you achieve that, then you will probably have a good test-retest variability or a range of variability. So what we're aiming to do is to have our own normative values. So if you are setting up this service, see the population that you're testing and have a range of variability that you consider within normal. DPOEs are not the same as audiograms, so you don't have a flat DPHL level, but each person, it's kind of like a fingerprint. Each person has their own kind of pattern for their OEE response. So you can use each patient as their own control and then compare them in the serial monitoring. So when you're assessing the OEE results, you need to establish whether they're within normal range or not to start with, and then when you're monitoring them on a serial basis, you check whether it's present and still within your normative range of variability, and I'll talk a bit about repeatability, or if it's still present, so you still have a 6 dB signal-to-noise ratio, but actually the amplitude has dropped, and dropped significantly to be outside your normal test-retest variability. And here, this is an early sign of damage. or actually it's completely gone and it's absent. So this is what we're aiming to look for. This is just to show you that OEE equipment now is becoming really portable. This is the recent Autodynamics Autoport equipment, and as you can see, this can actually deliver fully diagnostic DPOE testing. So it's handheld, portable, can store lots of tests within that equipment, and you can take it to the patient and test them. And you're aiming to have a recording like that with very low noise levels and a nice detailed recording of the OEE, rather than what we've got up here where the recording is quite noisy and the averaging is, you need more averaging. And to achieve that, it takes just over 2 minutes to do that if you have a deep probe fitting and a quiet environment. Because the noise levels are higher in the lower frequencies, we can actually just focus on the 2000 hertz upwards range and use that for our monitoring. And this is a preset, this is the interacoustics equipment, and it has a preset protocol for DPOE monitoring that you can use, and repeat that, setting your own normative values for your department. So regarding repeatability and what change is actually significant, this is an example of work that we did with School OH children. Suparna Bali did that as part of her research project, and she was looking at repeatability of OEE testing when you remove the probe and replace it again, which is one of the key factors that changes the variability. And as you see, all three recordings are very, very similar, with a very small range of standard error of measurement. And lots of other studies were done with adults and with newborns to look at this test-retest variability. And basically, if you assess these, work out the standard error of measurement, you can work out through a calculation something called the minimum detectable difference. So the difference beyond which, if it's higher than that difference, it means that this is an indication of cochlear damage. So these different studies kind of gave you different levels or different regions, different cutoff ranges to use. And the study by Rivas et al. Last year did a meta-analysis of 10 studies that were assessing test variability for serial monitoring of cochlear function in adults, normal hearing young adults. And they assessed 4 different frequencies. So the data from the 10 studies kind of provided enough information to pool them for these 4 different frequencies at 4 different timelines. Actually, this one was an exponential, but all these different timelines. And as you can see, with the 90% reference limit, this minimum detectable limit with a 10% possible false positive rate, none of these levels exceeded 6 dB. So to make it a bit easier, you can say within this range of frequencies, if you have more than plus or minus 6 dB difference, this could be considered as a sign of cochlear damage. For the higher frequencies beyond that, Drischbach et al. In 2005 did the repeatability of high-frequency DPOE testing, and they showed that it was still very repeatable, but not as good as the lower frequencies. But they reported that within a variation of high-frequency DPOEs of 10 dB, 87 or 83%, depending on the intensity level that was used, was repeatable. Which was much higher for the lower frequencies, but it's still very repeatable. So when you're testing a higher frequency, then use maybe that 10 dB range rather than the 6 dB cutoff. And they recommended that if you're going to monitor high-frequency DPOEs for things like ototoxicity monitoring or noise-induced hearing loss monitoring, then a change of 10 dB would be noted. If it's a change of more than 10 dB is noted at adjacent frequencies, first repeat, the testing to ensure that this isn't an artifact, and we repeat testing in audiometry, in electrophysiological tests, in every test that we do on audiology. We should be repeating it in DPOE and OAE testing as well, but if it is repeatable at that session, then this is considered a significant change in the auditory or cochlear function. Just a few things to keep in mind, or caveats, if you are going to use these kind of significant change criteria. Make sure that this is data that was obtained from young, normal hearing adults. So if your population is a different age group or a different kind of population, check that you have the right kind of range or variability. So if you are testing cancer patients that are older at age, having signs of presbyacusis or noise-induced hearing loss, maybe you need to have your own test-retest variability. We have seen through these two studies that stimulus level, frequency and level have an effect on your test-retest variability. So the lower frequencies have a smaller range, whereas the higher frequencies have a higher range. So keep that in mind. Also keep in mind that the clinicians have test-retest variability. So if somebody is accurate in their testing, have good repeated insertion of the probe and test them in very similar conditions, then their test-retest variability will be quite small. Whereas someone that maybe does things a bit faster, they would have a bigger range. So take that into account. So if you are going to use DPOEs as your initial kind of serial monitoring tool, use these criteria, and then if there is a significant change, go on to do further testing, more detailed and more frequent testing, using the audiometry and using more repetition so you can confirm that the hearing loss is happening, and then inform the clinicians and make sure that that is taken into account. You need to also take into account different risk factors or predictors of ototoxicity. Several research publications have shown that the better the patient's hearing before exposure to ototoxic drugs, the more the significant effect will have on them. So the drop in their hearing would be more significant if they do. Also, concomitant exposure to radiotherapy or exposure to other toxic drugs would have an exponential cumulative effect. So you need to keep these risk factors in mind as well. Reporting. As you saw with the data from the oncologists, we need to provide them with reports, whether it's a written report or something like this. When we were developing the ototoxicity monitoring protocol for the cystic fibrosis unit in Great Ormond Street, we developed kind of a simple sheet for them with just tick boxes saying, is their hearing stable or not, is there deterioration, and what to do next. You can develop your own, just make sure that you're putting information to the clinicians that's clear and doesn't require them to actually interpret your test results on their own, because they don't have enough training to do that, and they need to look at a lot more other things, so to make it easier for them to actually use this information. If you are developing this service as a new service, please keep in mind that your service is as strong as its weakest link. Make sure that every member of your team is keen, involved, and aware of their roles and responsibilities when they're doing this, when they're within that monitoring protocol. Make sure that you audit your service at least on an annual basis to see where things are going wrong. Sometimes just not getting the right referral at the right time makes the whole thing fall apart, so keep that in mind. I also want to bring your attention to this document. The American Academy of Audiology in 2009 published a position statement and clinical practice guideline on ototoxicity monitoring, and it's a really, really useful document to have a look at. But within that document, they also highlighted that audiology professionals are in a position to take a lead in developing and setting up these services and establishing good links with physicians that treat patients that are exposed to these ototoxic medications, specialist nurses, pharmacists, and everybody, and to make sure that they are part of that team, that they also contribute to professional educational programs to increase awareness of the importance of monitoring for ototoxicity and managing patients that are exposed to that. So take-home messages from that. I hope I've convinced you that DPOEs can be very useful and effective ototoxicity monitoring tools, especially in unwell, bedridden patients that need our help. The repeatability and the accuracy of the testing can be established by consistent, deep, good probe fitting and testing in a quiet environment with established normative data. And to highlight that we do have an urgent need to have a national ototoxicity monitoring protocol so that we can all have or provide a minimum consistent level of care, because it is kind of hit and miss in different areas, and we don't want that to happen. This is in line with what the WHO has been recommending since the 90s with the roadmap for prevention of hearing loss, and I just want to highlight here that ototoxicity has been identified as one of the preventable causes of hearing loss, and something that we need nationally and internationally to do something about. So hopefully on Monday, when you go back to your clinics, if you don't manage ototoxic patients or if you don't pay attention to them, maybe have a look whether you do see these patients and maybe revisit how you're testing them and how to make it more effective as a tool for improving their quality of life and helping them. Just want to finish by thanking all the people that I've worked with in some of the results that I've presented here and in other research that we've been doing with ototoxicity. And thank you all for your attention. Thank you.
Thank you.